Good evening and welcome. I'm Jeffrey Anderson from the Peace Studies Department, and it's my distinct pleasure to welcome you to the keynote address of the 29th Annual Peace Studies Conference. The keynote address is titled, Toward the Beloved Community, Ending Racial Disparities in Health and Wellness. Joining the Peace Studies Department in this co-sponsoring of this event are the CSB President's Office, the SJU President's Office, the Pre-Med Club, the Black Student Association, the Global Health Affairs Club, and the Peace Studies Club. After this talk, there'll be a book signing at 8:30 in the lobby, and there'll also be members of those four sponsoring student clubs available to meet and greet for you to find out things about their organization and to see about getting involved. We come together this evening, some on the receiving end of health disparities, some as distressed bystanders to a failing system, and some whose daily job is to help people live healthier. What unites us, I believe, is the conviction that we can and must do better. I want to mention one other funder, or two other funders really, of this conference, and that's Robert and Lorraine Breitenbucher, who are deceased, but they funded our conference for these 29 years and have helped us fund it into the future. Robert Breitenbucher was an MD by occupation, but he and Lorraine had a preoccupation with the disparities that people faced. Health disparities in particular were always on their minds. When we do our best work here at St. John's and the College of St. Benedict in our college education, we both introduce you to amazing ideas, and we hope to develop in you a preoccupation similar to that of the Breitenbuchers. To become preoccupied with something like health disparities, you simply need to take the initiative to get involved, and we have a host of ways to do just that. I want to take just a moment to mention some of those. The Mayo Innovation Scholars Program. Naisha Ford, right in our front row. Do we have other scholars here from that program? That application is due September 29th, so you need to take initiative relatively quickly. All right, for those of you who don't have quite that much initiative in that short a time, we have Brandel Fellows, we have Jackson Fellows, we have a Lindmark Fellowship in Professional Ethics, all of which could be addressed to these issues of dealing with health disparities. We also have groups on campus like the Global Medical Brigades and VITA, which each spring send about 35 on each program to do global health work in Central America. We also have all our alternative break experiences. And I'm happy to announce tonight, or to maybe some of you already know this, but the Guatemala program for spring of 18 will now focus on medical Spanish and public health. And one personal pleasure I've had over the last month is I've been working with 32 Fulbright applicants, several of whom hope to do their host country engagement through community health work. Now it's my pleasure to introduce Emma Bonglock, who will then in turn introduce Dr. Tweedy. Emma will graduate this May with her degree in biochemistry. She's won numerous science awards and research opportunities. Her undergraduate research involved using a reductive amination approach involving chiral atom amides to selectively set new chiral centers. There is a test on this, by the way, so be ready. By extending this method to include phosphite nucleophiles, we will be able to access biologically important phosphonoamino acids with stereochemical control. All right? And yes, just so you know, this is also a plug. I did use YouTube to get the proper pronunciation for amination and amides. Notice the hard E and the hard I, just switching it around to keep me on my toes. 11 other people had viewed the same YouTube, so now it's up to 12 views, and actually, I hate to say it, but actually 13, because I'm not that fast of a learner. Okay. Outside of CSB, she's been infinitely more productive than me in the summer. In the summer of 2016, she worked for the Food and Drug Administration researching Premarin. In the summer of 2015, She was at Yale, and she amplified some DNA using some PCR. Okay? I'd tell you more, but YouTube didn't have the translations. Okay? And then in the summer of 2014, she was at a pharmacology lab at UNC Chapel Hill, engaged in cancer research. Okay? Another thing that she can do that I can't is dance, where she's been very active with the dance team and the Element dance team as well. So anyhow, it's my distinct pleasure to have you join me in welcoming Emma Bonglak.
Good evening, everyone. Being a minority in America, it is without question that the racial disparities faced by minority communities is an obvious and sadly persistent problem. One of these is within the healthcare sector. According to the United States Census Bureau, Blacks make up around 13% of the nation's population, but only 4% of its practicing physicians. This is a gap that greatly harms Black patients and is an issue that our guest speaker, Dr. Damon Tweedy, seeks to address in his New York Times best-selling book, Black Man in a White Coat. In this book, Dr. Tweedy, who is also a graduate of Duke School of Medicine and current associate professor of psychiatry, highlights quite a few of his personal experiences with race and health, both as a medical student and a practicing psychiatrist. The book, which has been described by USA Today as fascinating, engaging, timely, and thought-provoking, could not be more relevant for our time, especially as the racial disparities that have already existed for decades are finally beginning to gain much-needed attention. As Dr. Martin Luther King Jr. once stated, of all the forms of inequality, injustice in health is the most shocking and the most inhumane. So ladies and gentlemen, without any further ado, please help me to welcome to the stage Dr. Damon Tweedy.
Thank you for that very nice introduction. You sound like a very accomplished woman, very impressive, yes. So good evening, everyone. First of all, I want to thank the annual Peace Studies Conference organizers for inviting me, extending this invitation. This is my, so I'm pretty tall, so I think I'm going to need to adjust this here. Back's starting to hurt a little bit. There we go. So this is my first time in Minnesota, actually, and so I've been traveling quite a bit over the last year. And every time I travel to a new place, I tell my sons where I'm going, and we can do like they're 8 and 6, and we get to do a little bit of a geography lesson. So now they know the capital of Minnesota, they know all the largest city, they know the pro sports teams. I tried to tell them about the lakes, and they still are very skeptical about this 10,000 lake thing. They refuse to believe. I told them it's actually more than 10,000. They're not having it. So. But Minnesota is also, known nationally for having a history of supporting progressive causes. And so I think in that spirit, I think that's why I've been invited here today. And I've been asked to prepare remarks about the theme of the conference, toward the beloved community, ending racial disparities in health. So that term was a term that was frequently used by Dr. King to describe his vision of a society in which the ills of poverty, bigotry, and prejudice could be replaced by what he called an all-inclusive spirit of sisterhood and brotherhood. Now, as we all know, that remains an elusive goal in our divided country and world. Fighting racial disparities in health is a crucial part of creating this beloved community. And King addressed this during his life from the quote that you just mentioned. So that quote comes from 1966. When Dr. King was actually speaking before a group of physician activists in Chicago, which is where he sort of made his home in the last few years of his life. And he made the following quote, again, of all the forms of inequality, injustice in health is the most shocking and the most inhumane. Now let's go back in time a little bit. This is 50 years ago now. And so at the time of his remarks, the health differences between the Black population and the white population was striking. It's still a problem now, but it was striking then, especially in the South. So Dr. King, when we think of him, we think about Alabama, we think about Mississippi. Those are sort of the areas we think about Dr. King. And the life expectancy for Black men at that time, in the mid-1960s, was a decade less than for white men. So it was like 9.5 years, the life expectancy. Man, that's incredible, right? It was like 74 for white men and 64 for black men at that time. And among women, it was about 7 years during this period. So during this time, the Civil Rights Act was passed in '64, Medicare and Medicaid were established in the mid-1960s, and that did lead to significant progress. Nevertheless, when I started medical school in 1996, so we're talking 3 decades after Dr. King's remarks, just 20 years ago now, I still bore witness to the King's concerns. And so I'm going to take you back to that time and sort of talk about that experience and how that leads to the present. So it all started for me in the classroom, just like you guys. I was once young and in classes. And so during that first year of medical school, we learned about all the common diseases: high blood pressure, diabetes, cancer, as well as things that were less common, things like lupus and fibroids and sarcoid. And so the professors, whenever we would learn about diseases, they would always start off by telling us about the pathology of the conditions, how it affected the body. And then towards the end, they would transition to what they call the social factors or the demographic factors of disease. So who was affected more, men or women, young or old, that sort of thing. And whenever it came time to talk about race and ethnicity, there was the same refrain over and over again. Disease X, whatever it was more common in blacks. Disease Y had a worse course among blacks. And disease Z was more common among blacks and it had a worse course. The message was, being black is bad for your health. That was the message that I interpreted as 20 years ago. But why? And what could be done about it? So that was the questions that were going through my head as I'm sitting here listening to this information. But there were no answers really offered. One time I asked the professor about it, a couple times actually, several times, and they say, well, we don't know, it's just the way it is. Some would hint that it was some kind of genetic issue without any sort of explanation as to what that meant. And I remember sitting around the classroom looking around and wondering what all my classmates, what did they think about this? Like, did they think it was somehow, did they think it was genetic? Did they think it was somehow the fault of black people? Did they even care what this information meant? So there was that intellectual part for me, and it became emotional, and it had a much greater, it was more than just what I was learning in the classroom, because it began to affect my actual life in a personal way. So shortly before I started medical school, my maternal grandmother became severely ill, gravely ill. So she had a long history of, she'd had high blood pressure for much of her life, and during my senior year of college, she suffered a few mini strokes. And the first few strokes didn't really, she was able to recover well. But then the last stroke she had was very serious, and it caused both physical and mental impairment. And during the summer after college, she also developed acute heart failure. And she died a few weeks into that first year of medical school. So you think about those conditions she had: high blood pressure, stroke, heart failure. So these are all diseases that were more common among black people and were associated with worse outcomes. So it was the same narrative that I was learning about in the classroom affecting my grandmother. But then several months later, the concerns became even more personal to me. So one afternoon, so when you're a medical student, the way you learn how to become a doctor and do the doctor things like check blood pressure and draw blood, you actually practice on one another. I actually have some funny stories about that we can talk about later. But so one day we were practicing, and a classmate of mine was measuring my blood pressure, and she found that it was high, very high. And our first thought is that she didn't know what she was doing. We were all just learning for the first time. Checks it again, it's still high. And we bring the professor, the faculty person in, and he confirms that it was abnormally high. So as you may hear, doctors aren't always the best patients. So it took me a little while he recommended that I go to the student health clinic, and it took me a little while to do that, but I eventually did that. And when I got to the student health clinic, the blood pressure was high. And then they drew some blood and got a urine sample, which is a common thing you would do if someone has high blood pressure, and they found even scarier problems. They found that I had some early signs of kidney disease, which is a really common complication of high blood pressure. So there I was, 23 years old, feeling like I'm really physically fit, vibrant, on the top of the world. I'd played sports in college, and here I'm being told that I have these chronic diseases that are more common among black people and have a worse course. So the questions of why and how to fix the problem, so it became like an obsession for me to try and understand what this all meant. And as I went through my clinical rotations, I began to see the many reasons why being black can be bad for your health. So what I do in the book is I use narratives of people that I encounter throughout my training, and I show how the impact of where we live, where we work, where we go to school, whether we can get access to medical care, and if we can, what quality care we can get, how all those things really impact health. And that's really the crux of my book. What I try and do is humanize those stories and sort of shed light on the struggles of people that often get really lost in our divisive culture and soundbite nature culture. So let me give you a couple examples. So early in medical school, I volunteered one Saturday morning at a rural clinic. It was about an hour and a half east of Duke. And the small town had about 2,000 people, no physician in that town. And Duke had this arrangement where a faculty member would go to this clinic once a month, one Saturday a month, and he'd take a bunch of medical students with him. And when we got there, so the town was 50% African American, but when we got to this clinic, all the patients there were black, all of them, 100%. And it was pretty clear pretty quickly that what we face as the medical team and what the patients face was so different. The obstacles to getting care was so different than we would see at Duke. So one woman we saw, she had high blood pressure and fibroids. Fibroids are when you have enlargement of the uterus, and it can cause heavy bleeding during a menstrual cycle and cause pain. So these are very treatable problems, but she worked a full-time job, but it was the kind of job that we too often have in America where it didn't come with health insurance. And we couldn't address either of her problems adequately. And our supervisor, this is what he told us. I think this is amazing to say. This is amazing. Just think about what he said. So he said, well, the problem is that she's not actually sick enough to get care. So if she got sick enough, then she could come into the safety net healthcare system and get care. So you have to actually get sicker. You have a treatable problems, but you have to get sicker to actually get treatment. That was just it was insane, right? It's just totally insane. And over time, I saw many other situations where like social and economic factors dictated treatment. But sometimes it was more explicit than that. Sometimes there were actually issues between the doctor and the patient and how doctors perceive patients. So I'm going to give you another story, and this is from me as the patient. So this is actually fast forwarding through some years now, and I'm in my early 30s at this point, and I played sports and had a knee injury years ago in college, and I was, at this point in my life, in my 30s, I was like a weekend warrior kind of person and trying to do more than I could. Re-injured my knee, and then again, I mentioned earlier that I was not always the best patient, so it took me a little while to get to see the doctor. So I'm not encouraging you guys to do that, but that was sort of my stubbornness. And then when I was working in the yard one day, cutting grass, and that knee pain sort of aggravated again. And I went to I said, I think I need to get this checked out finally. So I went to like a urgent care clinic. And as you can imagine, I was cutting the grass, so I wasn't dressed in a suit as I cut the grass, right? So I had on sweatpants, I had on tennis shoes, some kind of old, kind of beat up t-shirt. And I got into this urgent care clinic, and the nurse there was very pleasant, very nice. It wasn't a particularly busy day, and she checked me back into the room. And then when I get in the room and see the doctor, first thing is he never makes eye contact at all with me, at all. He goes straight to the computer and says, I see you have knee pain. Can you stand up? Can you sit down? Okay. And can you stand up? Can you sit down? And then he's like, you're okay. So first of all, he didn't know anything about me. So he had no idea how a knee injury could impact, he had no idea what kind of job I had or how a knee injury could impact my life in any way. He knew nothing about me at all. And he's just like, your knee's not, it's not a life-threatening injury, so you're okay to go home. So I'm a doctor, so I'm not someone who actually tells people that I'm a doctor when I meet them. That's not the first thing that I'm going to say or wear that on my shoulder. I am a doctor, right? So that's not what I do. That's not how I interact with the world. But I feel like at this point, I probably should speak up for myself a little bit. So, but I did it in a subtle way. And I said, I used some vague-sounding medical terms to sort of give a sense that maybe I knew a little bit about what was going on. And his response was, are you a tech, a health tech? So he was already still kind of putting me in a certain box. And I said, no, I'm actually a doctor. And the entire encounter completely changed. So at that point, he looks at me for the first time, really actually looks at me, and he takes an interest in me, and he comes, and he slides his chair over, examines my knee, like you're supposed to from the beginning. And suddenly there's like this alarm. We've got to get an x-ray. We've got to get this. We've got to get that. And so I was like, wow. It was really an illustration of being two different people in one setting. So the first person was the 30-year-old black man who's dressed in sweatpants and tennis shoes. And then the second person is a doctor. And so it was a powerful illustration of how different care could be delivered. So some people would say that, well, that doctor was just a bad doctor, but in fact, what he did subsequently demonstrated that he actually knew what he was supposed to do, but actually chose not to do in that first encounter. So those are the sort of things that I describe in my book, and these are some of the factors that impact how care is delivered and the kind of care that people actually get. So there's layers of structural issues that I talk about, but then there's issues between doctors and patients and how they interact. So I'll have more to say about how we address these problems later on, but then I wanted to kind of switch gears and tell you another important part of this health disparity solution, or problem, I should say. So there's a true dearth of black physicians in the country. As you alluded to, African Americans make up about 13% of the US population, but about 4% of practicing physicians. Now that 13% number is kind of misleading, because in many locations where a lot of the medical schools and hospitals are located, the numbers are much, much higher. So you think about, so I'm in Durham, North Carolina, it's 40% African American. You think about a lot of the cities we hear about in the news over the last couple years. Baltimore is 60+% African American. St. Louis is almost 50% African American. Atlanta, so these cities have really, really large African American populations, and there's a lot of tension between these communities and these medical settings. So what's come up a lot is, and a lot of what my story's about, is what is it like for me as a black person, a black man going through the medical training process with this reality? And so what I found is that it's all about perception. The perception of what others have of what it means to be a black man in America. And I'm going to take you through some of the experiences that I had, and some of those are certainly filled with certain highs and many lows as well. So I'll start with some of the lows. So as a first-year medical student, I was in a class, and it was a break between classes, and in the lecture hall, I stepped out to use the restroom, and came back into the lecture hall, and the professor approached me as I came into the lecture hall and confronted me actually at the entrance and said, "Are you here to fix the lights in the room?" And my first response was to think maybe there was someone else around me, maybe I'd misheard him, that kind of thing. And then eventually we had a back and forth, and he was irritated, and he said, "Well, I called about this last week. Why have you done this yet?" And I basically summoned up the energy to tell him no, that I wasn't why I was here. And then his response was, then why are you here in my class if you're not here for that purpose? So that was the exchange that we had. So that's obviously a very unfortunate exchange. And so for me at that moment, I was thinking, I was angry, but I was like, well, how am I going to, this guy's got control over my grades, et cetera. How am I going to sort of respond to this? Am I going to talk to administrative folks? Are they going to understand what my experience is like? Are they going to think that I'm sort of just trying to make something up or misinterpreted things, and maybe give him the benefit of the doubt because he's the professor, he's been there for a long time, I'm this new person at the school. So, in the book I talk about how the only way that I could sort of make peace with it was to sort of just study and prove to this guy that I belonged in his class. But it was a really unfortunate situation, that I encountered there. So that story is talked about in the first chapter of the book, and I don't want to give away all of it. But also during that same first year, I had another experience, which I don't actually talk about in the book. So this was actually the end of that first quarter. I'm driving back home to Maryland, and I get pulled over, driving back home in North Carolina. I get pulled over by a police officer, and so I'm dressed, again, not like a medical student. My ID badge was back in my room, and so I'm dressed in shorts and T-shirt and driving home to Maryland, get pulled over, and he said I was speeding. I contend to this day I was not, but what are you going to say in that situation? And so I get pulled over, and this is daylight, and the first thing he says to me is, do you have a gun in the car, and do you have drugs on you? And so I was thinking, wow, this is gonna go bad really fast, and so it was this reminder of, so I was a part of this world at Duke, right? This part of this sort of elite medical institution and becoming part of that, but it was this really stark reminder of how you get a few minutes away from that, and the perception of you in the world is so different, and you're suddenly perceived as a threat and a criminal. And so that was the experience. And then there was this, he mentioned to me that there was someone who committed crime, and somehow I looked like this person. It was all this sort of stuff that just went on and on and on. And so, I mean, so that was just a really painful episode as well, as a medical student. So we fast forward a few years, and I finished medical school, and I become a medical intern. So that's the first year after you have an MD and you're a doctor, and So you have the doctor behind your name, but you don't really feel like you know what you're doing as a that much. It's still very inexperienced. The doctors in the room will know what I'm talking about. So as a medical intern one night, so the very first couple months into that experience, you're trying to adjust to just all the pace of trying to, like you're writing orders for people, and you're like, well, I'm writing an order in a chart. Does that mean, wow, this person's really going to get this drug? Like, I'm really the doctor? That's sort of the kind of thinking you're thinking to yourself. Like, there's a story I tell in the book where a nurse is like, this person has pain, and what should you give him? I'm like, well, what do you think I should give him? And, and the nurse is like, you're the doctor, And so that's the kind of adjustment that you really go through in that very beginning. So you're going through that huge adjustment of trying to learn and be responsible for people's health and well-being, and that's hard for anybody. But then for me, there was another layer added to that story. About 6 weeks into that experience, one night in the hospital, an older gentleman comes into the emergency room, and he hasn't been in the healthcare system in a long time, and he's looking around and seeing some black staff members there. He's never been to the hospital here, and he's getting agitated about what he's seeing, and he makes the comment out loud that he does not want an N-word doctor to take care of him. Now, as fate would have it, or however you want to characterize it, I was the only African-American doctor it was a team of rotating doctors that covered the hospital, 30 or more, only one, and he happened to be assigned to the team where I was the doctor, despite his against all of his wishes. And so it got worse than that. So when I met him, I described his perspective, but then his daughter had one of those shirts that had the Confederate flag, huge Confederate flag on her shirt, and then he had another relative, a grandson, who had a Confederate flag tattooed. They were really obsessed with the Confederate flag. It's tattooed. I'm like, that's like, geez. And so my first thing is, wow, this is a really bad situation that I found myself in. And so you just imagine being that person in that situation, just trying to struggling with learning how to be a doctor and having this extra layer placed upon you. So there are many other stories that I can tell, and I'm happy to talk more as we go to the question and answer part. But really, these stories are part of a much larger experience that many African American medical students and doctors face. So, see, some people, when I first started publicizing the book, and there's some people that have a bias against the South for obvious reasons, historical reasons. Some people have a bias against Duke because Duke does not have a great reputation historically with race. And there's some people that want to limit it to that. And, well, this is a relic of just being in those parts of the world and the country. But what I've learned is that I've heard experiences from doctors from every corner of this country. They've had the same set of experiences, some far, far worse. There's a doctor that one of their story that really stands out. He's from a school, I won't name the school, but up in the Northeast, very thought to be a very progressive liberal institution sort of thing. And he recalled a situation where he was a medical student, and there was a patient on the service, and the team thought the patient had a Spanish-sounding last name. And, there's this thing that people do when they think a person doesn't understand the language, they just yell louder, like that's going to somehow make it work out. And people do that. I'm sure you guys have seen it happen. And they would just yell at her every day and yell and yell and yell. And then one day she said, well, she pulled him aside and like, why are they yelling at me? And he says, well, they don't think you understand English because of your last name. And then she said, well, that's funny because that's actually my married last name. I'm actually, so the team had never taken the time to figure out any of this information. And then when he conveyed that, this is the best of the bad part though. So that's sort of the funny part. But then when he conveys this information to the medical team, their reaction is, you think they may say, oh, gee, thanks for, helping us. They took offense to this. And so they actually sabotaged his evaluation and said that he was trying to become a, how do they put it, a new age Malcolm X radical on his record. So he had the fortune, of course, in his case, to actually have had a good relationship with the dean of the school, and they were able to sort of, redact that recommendation. But you see how it could have potentially sabotaged him, right? And so this is the same time period that I was coming through school at a different institution in the Northeast. And so these experiences, that's just one example. These experiences are sort of much more emblematic of a larger problem. But I do also have a lot of good stories to tell as well. So, some of my stories from my journey were the same as any medical student or young doctor might have. You make the correct diagnosis under hard circumstances, you learn how to do procedures, but then there were other things that were really specific to being an African-American doctor. So for me, you know, there are a couple examples that I talk about in the book, and there's one, and actually there's several. One was a time when I was able to well, a couple times actually, when I was able to help people who were middle-aged black folks who had never seen a black doctor, had issues with diabetes, high blood pressure, and were very suspicious and skeptical of the healthcare system. And I was had gotten into this role where I was almost like a translator to them, and being able to sort of reassure them that these things were really the appropriate treatments for their conditions, and were really able to sort of reverse serious problems and avert real disaster for them. Later on, as I became a psychiatrist, I was able to help, just one story I talk about in particular in the book, where I help a young black woman really address the stigma of mental illness and her struggles with her own racial identity. So she was a biracial, her dad was black, her mom was white, and she had a lot of issues around that, and I was able to really help her with that in a way that was really unique to the idea of my own experiences as a black person. But what happened all too often is I was one of only the few black medical providers in these various settings. And so a clinic we were in would be 50% African American, and I'm the only black provider there. And there'd be this sort of situation where they'd want me to see so many patients, and I'm only just one person, right? And it was sort of like this. And so it was a stark reminder that I was in some ways alone. And so there's actually a report that came out last year. There's an organization called the Association of American Medical Colleges. They're in DC, and they're basically like, they collect a lot of data on medical schools throughout the whole country. And they published this report last year that got quite a bit of media attention. So they found that black male enrollment in medical school had actually stagnated from 1978 to the present, so completely flatlined. Now, that might not seem like a bad thing but when you think about how population changes otherwise have changed since 78, that's remarkable. So the overall US population has increased a lot since 1978. The population of doctors has increased a lot. And it's increased in every other demographic group with the exception of black men, considerably. So now so much so that now you'll see black women outnumber black men in medical schools 2 to 1, 3 to 1. It's a really common phenomenon. And you won't see that in any other demographic group. It'll be more like a 50-50 or still even more men than women split. And so, you know, what's behind that? So much of it is still about the same things we talk about as far as where we live, where we go to school. I think perception's a big piece here. You know, the way that society views black men in the way, sort of the lanes in which you're, what's opportunities available for you. So I had a chance to share a story with your president. So when I was in like 9th grade, I had a teacher. He was also an assistant basketball coach, and he actually told me that, you know, the only way that I was ever going to be able to go to college was to play basketball. Now, he didn't know anything about me. He had never seen me in a classroom, but that was what he told me. That was the only way that I could get to college was to play basketball. And then I said, you know, sir, but I have a 3-point, whatever it was, GPA. He's like, oh, yeah, okay, that's good. So with that, you can probably get a 800 on your SAT. I mean, see, he'd already sort of limited. He'd already had his vision of what I could be in life, and so these things have tremendous impacts, you know, on people and where they come from. Particularly for me, because I came from a family where my parents did not go to college, and I'll say more about my family background later. But I think that's a big part of the piece of why we're still struggling to get people in this field. So, you know, my book's been out a year, so I want to tell you a little bit about the feedback. I think this is really, you know, illustrates a lot of where we are as a society. Because, you know, in some ways, when you talk about race, it's almost like you say a statement and people project their own feelings and emotions onto the subject. So let me tell you, I'm gonna give you a little bit of sense of that, because I think this is really interesting. So, you know, obviously, much of the feedbacks come from black medical students and doctors, and they talked about how my experience relates to their own. A lot of them have been in other fields, law and business, and had similar experiences. I had a lot of white readers, though, who said that they had no idea these issues even existed. So when you first get a book published, you have to, all the publishing industry is based out of New York. And so you submit this information, your proposals to editors, and they're all college-educated type folks. And I remember the response that I got was like, wow, this is really happening, and they were like completely just blown away. Like people know about disparities in criminal justice, people know about that, but this idea that there is issues in health, it just speaks to this idea of how so easy it is to be marginalized in our society if you're if you live on the margins. But I would say that the response has been positive for sure, but to no one's surprise, I've had a lot of negative responses as well. So whenever you talk about race in a candid way, you're bound to offend a lot of people. So, you know, I anticipated the negative anonymous comments you get. You know, it's really amazing what people will say to you when they they don't have their name to it, and they can just say anything and everything about you. They don't know anything about you. So I've had all sorts of experiences like that. But then I've had some that I think have been much more concerning because they're actually from physicians. And so, yeah, doctors are we're prone to prejudice just like anyone else, right? But it was really troubling when I had some practicing doctors. They suggested to me that, well, this with race and ethnicity was once a problem in America, but it has no longer a problem at all, has no issue at all. And then one doctor said to me, the problems of the health problems of the black community are only the problems of the black community. So just imagine how that doctor must interact with black patients if he already comes into the room and has that perspective. So I think really all this feedback, good and bad, it underscores the need for these messages that are in my story to really continue to be circulated out there and disseminated to a larger audience. So I think that brings us back to the end. So how do we end these racial disparities in health? So I think that there's really no simple answer. And so many things really have to happen in concert all together. So first, we have to seriously address the numerous factors that influence health, right? So we have to talk about education, access to jobs with a decent wage, reduction in racially segregated living arrangements, and so on. So I mean, in medical school, they just teach you about biology, chemistry, the science, but it's so, when you get and start seeing patients, you realize that so much of what happens in health is so little about healthcare, but it's about what's actually happening to the person outside in the world outside of before they ever get to the hospital. And that's something that schools just really have not done a good job with instructing. So I think within the healthcare sector, we have to expand health insurance, obviously. And the thing about that that's always amazing, we obviously know how incredibly politically divisive that is. But I've always noticed that, people get diabetes and cancer, whether they're Democrats, whether they're Republicans, whether they're independent, it has no political connection at all. Yet we've somehow found this way to politicize healthcare in ways that are just devastating and actually just completely insane. So I think at the very minimum we have to expand health insurance. I mean, but that's just it's a necessary component, but it's certainly not sufficient to address all the problems we need. We also have to find a way to empower patients, with the resources to take better control of their health. We have to do better at selecting medical students that are more compassionate and teach young doctors of all backgrounds how to recognize their potential biases. I think a really important thing when you're a doctor and you go into a community, so the hospital is such an insulated place, it's an elite place, but you have to be able to understand people and reach out to the communities and reach people out in the communities, know where they are, understand the community's issues, but also then when you see a patient in your practice to be able to see that person as an individual. I think these are all really important things that we are still struggling with in our society. So there's a story I think that sort of illustrates that, and this is sort of this is a case where I'm the black doctor and the patient actually was white. But I think it's a lesson that any doctor can use as they move forward in treating people as individuals. So there was this guy, so this is me as a psychiatrist, and this is a guy that I saw, and he was a veteran of Iraq and Afghanistan, and I'd inherited him from another doctor, and I'd sort of taken over for that doctor's clinic because he had moved on. And so I'm looking at the patient's chart, and as I'm reading through, I'm already forming impressions. This is how people work. This is how the brain works. And so I'm already forming impressions. Some are maybe good, not so good. And this is what happens to a lot of patients. I think this happens to a lot of black patients to their disservice. But in this particular case, the patient's white. And I see in this chart, and I don't want to offend anybody in the audience, but I want to sort of illustrate the contrast between this patient and myself. So the first thing I see is that he rides motorcycles. So I'm a kind of a chicken person, so I'm thinking motorcycles, ooh, that's scary. That's my first reaction. And then I see in the second thing he mentions that he likes hunting. So my dad actually grew up in the country, loved hunting, actually briefly belonged to the NRA and all that stuff. But me, guns are scary, ooh, not my thing. So that's my initial reaction to looking at his record. And then it says pickup truck. He likes to drive trucks. So my dad likes pickup trucks. And so I remember being a kid and hating to ride in his truck. Don't want any part of it. So I'm thinking pickup trucks, not me. And then it said enjoys NASCAR. I'm thinking myself, so my wife likes NASCAR, but I'm thinking NASCAR, they drive in circles, not my thing. So I'm thinking all these, I'm setting up all these contrasts between this patient and myself and how we're completely different, right? And so I'm already kind of going in the room with that sort of perception. And when he sees me, the look on his face is like, whoa, what in the world just walked in? It's like, so we're so different, right? He's probably looking at me, I'm dressed in my little sweater and my little cream. I look so, it's a complete contrast to him, right? He has like the hunting fatigues on. It's like this complete opposite contrast, right? And so when I first started talking to him, everything is like one-word answers. Yes, no, yes, no, yes, no. I'm thinking this is going to be quick, and he's never going to come back to see me again. And so at the end, I said, okay, let me just ask about his family. That's a universal kind of thing. And so then he mentioned a little bit that didn't sound anything I could relate to, but then he mentioned about his dad and how he and his dad like to shoot pool. So that's a pretty small thing. But it turned out that was something that my dad and I used to do a lot when I was growing up. And that was an instance, it was the first moment in which I thought of him as something other than like a series of stereotypes. I thought of him as a real person in a way. And so normally they tell you in psychiatry you're not supposed to disclose anything about yourself. You're supposed to just sort of be a blank slate, as they call it, and all that sort of thing. But I feel like this is a time where maybe this is a harmless sort of thing. So I mentioned that I like pool. And so, and then suddenly you can see a light flicker in his eye, like, oh, that's pretty cool. And that was the beginning of like a connection. And it only took a short minute. And so after that, he did come back to the next visit. And he came back for several more visits. He talked, and we started to talk about his relationship with his fiancée, and eventually they got married, and they had kids, and he went back to school. And so I sort of was able to follow him through different parts of his life and establish a relationship. And we were able to get past this initial sort of enormous gap and gulf and barrier that we had between ourselves. So I think that story is something that can be applied to anyone who's out in the field, right? So you have a black patient in your clinic who's so different from you. Let's say you're a white doctor, an Asian doctor, and you come from a background that's so different from that person. Still being able to find a connection with that person and see them as an individual is so important. So I think that's a big part of where we need to go when we're teaching medical students moving forward. I recently had the opportunity to meet and to hear the civil rights attorney and author. His name is Bryan Stevenson. I don't know if anyone's familiar with him. He wrote a book called Just Mercy. It came out in 2014. He has a TED Talk with like 4 or 5 million views. Check it out. I encourage you to do that. He's a civil rights attorney. He worked on death penalty cases for folks. Just a really great guy all around. And when he gave a talk, he said that there were 4 things that he felt like society needed to do to address reform within the criminal justice system. And I think they really apply to the healthcare sector just the same. So I'm going to just borrow those from him. Hope he won't mind. So first, he said, we must really be willing to be close to those who are struggling rather than run from them. Because that's a natural inclination, right? We do better, we move away, we run from problems, right? We don't want to go towards problems. But I think that's the first step, and that's so true. So doctors who are practicing in settings where people are struggling are working towards the problem rather than running from the problem, right? So I think that's a really big piece. His second one, so he called that proximity. His second point was that we must work to change the narrative of how marginalized people are viewed and described in public discourse. That's very true, and I think that's really what I wanted to do in the book more than anything else. Now I talk about people in really honest terms. That's not always flattering to them or to myself, but I'm trying to humanize folks and sort of give people a sense of what is it like to be this person in this environment, in this experience, and how does that impact that person's, what you see when they come to your hospital or exam room. I think that's a huge part to the story. Third, he said we must maintain a sense of hopefulness about the future and our dedication to seeing that as a reality. So obviously we know that can be challenging in the face of all that we see and hear. But then finally he said we must be willing to be uncomfortable as we grapple with the inequalities in our world rather than become defensive. That is not our problem, our fault or concern. So think about that, right? Because a lot of times when these discussions come up, people get really defensive. I had nothing to do with slavery. I had nothing to do with segregation. That's not my problem. My ancestors weren't even here when this stuff happened. People will get really defensive as if you're, and they have a really difficult time sort of sitting with the uncomfortableness of what's happening in our society and the inequalities that exist. So what I try and do, and maybe it's not, everyone has a different technique. I've been angry and I've tried this sort of angry approach. Didn't really feel like I got me where I wanted to go. So I've tried to be more to disarm people, to try and sort of make it more of a thing where we all have these issues, we're all in it for the same interest. But people have different ways of approaching it. I found that's more effective for me. But I think either way, we still have to be able to sit with that being uncomfortable. So I want to close here. So these issues are immense, but sometimes these issues are so immense that sometimes we can be paralyzed into inaction. But I want you to, there's another quote from Dr. King I think which is really important. I want to leave you with this. I think it really speaks well to this concern. And so the quote is that if I cannot do great things, this is what he said, I can do small things in a great way. So I want to leave you with a personal story that really illustrates the power of small things. So I didn't tell you a lot about my background, but I grew up in a community that was 100% African American, literally 100% African American. It was outside of Washington, D.C. My dad had grown up in Southern Virginia, did not finish high school, and he went to the military. That was sort of the way to get out of the community he grew up in. And he went to the Navy, and he didn't finish high school, and went to the Navy, and eventually settled in Washington, D.C., and got a job at a grocery store. I was talking to the driver, like, what are the stores around here? He mentioned Cubs Food and some place called Hiole, or I'm butchering it, blank. Cubs Foods, right? That's the store here, right? Cubs Foods, Cub Foods. Okay. Oh, so a store like that, so a grocery store. I really fell flat. I was trying to find a local analogy. So my dad worked for like a grocery store, and he basically worked in the meat department of a grocery store, and he worked nights, and that's what he did for his life. My mom grew up in Washington D.C. in the city with a single mom. And she did finish high school. She's actually a very good student, but realities of her life at the time, college was just not something that could happen for her. And so she ended up getting a administrative kind of secretarial job in the government, and she did that for her life. So together they got married, carved out a working class kind of life for themselves, blue collar life. And so I lived in a community, again, that was all African American. And in the community I lived in, so being a black man and going to college was not something that was at all something that you would take for granted or even necessarily aspire to. The only folks that I recall, basically they played basketball or football for men. That was like you get a college scholarship for track or basketball, football. That was the way to get to college. Now I had an older brother. I have an older brother, and he actually went to college as a regular student. And you know, many people across America would just take that for granted, but in my community, that was an enormous feat. And so to have that example in my home, I think, was a big part of my own being able to see that for myself. But nonetheless, the community I grew up in, there were a lot of negative influences. And so a guy a couple houses across the street from me, I'll just give you a couple examples of this to illustrate this. Now, it wasn't everybody in the neighborhood was struggling this way, but many were. And so a guy across the street from me, he's a few years older than me, and he got incarcerated when I was in high school, and then he got murdered in prison shortly afterwards. And so I was in high school at the time, and I knew this guy. And then there's another guy another door down, and he also got incarcerated for some drug-related charges. And then there was a young girl who had gotten pregnant when she was 13. So there was all these kind of negative influences and things of that sort that were in the neighborhood that I grew up in. So the school that I went to we have time. I'll tell you. So we initially got bused to a all-white school for elementary school. And there were a lot of incredible experiences that sort of illustrate how people perceived African-American students. So I'd done well on the math. I was always good at math. That was one subject I was always good at. And I did well on the math test. And his teacher just thought that was like an amazing thing. And she said to me, wow, and she looked at me and then talked to the teacher next to me and said, wow, you're really, Damon is this guy's really good at math. He did better than the other students in the class. He's not like the other animals that come to our school. And she said that. And I'm just sit right to me. And so there was that kind of, you could tell that just shows the idea of expectations and how that then impacts what people become. So fast forward a few years later, I go to a middle school, and it's my neighborhood community middle school, and it's 97% African American, something like that. And it would be called a low performing school by modern, what they call the terminology now. And then again, I was always good at math. So in 8th grade, a math teacher, I took a couple exams. The math teacher took interest in me. But unlike that other teacher who had this really sort of, really horrible perspective on life, she said, Damon, you really should take this test for a magnet program for a high school. And I think you have a good chance because you do really well in math. It was a math and science magnet program. And my first reaction, given my environment, my community, my experience, was to reject that offer, to think that was not something that would be for me, because that wasn't something that was people in my community had done. I wouldn't fit in, I'd be out of place, all those sort of thoughts that would go through your head. So this teacher persisted though, and she got my mom involved, which is always a good thing if you want to make something happen. And so she literally took me to the test site on a Saturday morning to take this exam. They literally dragged me to the test site. And when I got there, I kind of go through the motions thinking nothing's going to come of this. But then I found out a few weeks later that I got into this program. And that really was the beginning for me of being able to see a different place for myself in the world and how I could fit in a different way than how I'd always envisioned myself. Like as a 13-year-old, I could never conceive of being a doctor or any kind of person, any kind of scientist or any professional, anything of that sort. And so that was the very beginning of that, being in that magnet program. So you think about that teacher. She was a white woman who was in her mid-40s. A lot of teachers in schools like that would just kind of go through the motions, and just sort of put you through and not really take any interest in you. But she took the time to take interest in me. So she did a really small thing, and I really was able to transform my own whole trajectory in life. And so I think those kind of acts replicated on a larger scale have a real role to play in addressing these problems. So think about how you guys can do your own small thing, in a great way. And I want to say thanks again about just inviting me to speak about this. I really, in many of my experiences, having the question and answer sessions are often some of the best times. But before I close, I do want to say, thanks for this. This is really a great honor, and I'm open for questions. So thank you. Thank you. Oh, you don't have to. Yeah, it's okay. It's okay. It's okay. So, thank you, though. Okay. We can get questions now. Yeah, don't need to do it. But thanks. We don't need all that. But let's get some. So, any questions? I'm happy to take some questions from folks. Yes. How does this? So they have to come to the mic and all that.
Testing. Can you hear me? So you mentioned earlier Black Americans' skepticism, very briefly, their skepticism in the healthcare system.
Mm-hmm.
How pervasive is this skepticism, and what's your perspective on it?
Well, I mean, if you think about the history of some of the experiences that have happened, there's like an oral history in some ways. I mean, there's a real history. I mean, there's a textbook history, and there's also an oral history of these experiences that have occurred within the healthcare system. So, there's the famous study, the Tuskegee Institute study, which occurred from 1934 to 1972. So that's where the federal government was actually researching the natural history of syphilis in African American men. And they continued this study even after there was treatment available for syphilis. They never told the people that they had syphilis, nor that there was treatment available, and this lasted until 1972, right? So that's one of those sort of ghastly episodes in U.S. history. But that's just like the tip of the iceberg in a sense. I mean, there's many other sort of oral history of experiences of going to clinics and being mistreated in different ways, and it's sort of, in some ways, it's passed down. So I think it's it varies as far as the pervasiveness. I mean, what I would say to that is, there's no doubt that there are some communities where this is still an issue. And as I was saying before, often I'd find myself translating, being put in that role, which is a really interesting role to be in. But it just sort of speaks to this history that we have. But I don't think it's something that's insurmountable, though. I think it's the kind of issue where the medical system has to do a better job of meeting people at their level in the community, and not just sort of expecting the community to meet them at their level. So I think the medical system can take an active role in this. And there's been steps that have been to try and address these issues. But I think that's part of the remedy as well, for sure, is sort of engaging the community, but also having community, but they call them like patient navigators or community people, liaisons, who are people who are in the community, but they can sort of act as intermediaries between the healthcare system as well. So there's solutions to this, but it is still a problem, there's no doubt.
Would you mind telling us the rest of the family that had the Confederate flag tattoos and?
Oh, well, yeah. So it's actually, I chose this story in the book because I wanted to instill more of a sense of optimism. So in this particular story, the guy was terminally ill, and so he was in our hospital for several weeks. And during that time, I actually got a chance. I mean, so what really changed it was that one day he needed blood drawn, and no one on the staff was able to do it except me. And so, which is amazing, because normally I'm kind of a bumbling kind of person. But in this particular moment, I sort of transitioned to something else, and I was able to get blood in this guy, draw blood, and it was like this sort of like, oh, wait, maybe this guy is, competent after all, kind of thing. And that was the start of it. And then again, he made some connections with his family, and I got to know them a little bit, and I got to end up actually having a really interesting ending, because he ended up dying because he was terminally ill. That's what we discovered once he got to the hospital. But at the end of that, his family actually, when he died, my first thought was that, well, the family's going to blame me. I'm this incompetent doctor sort of deal, that kind of thing, and they're going to be racist and sort of thing. But they actually were tremendously grateful, which was really a surprising kind of ending to that initial episode. Now, I chose that story because I wanted to instill more of a sense of hopefulness and optimism, because I've had other cases where patients have not wanted to see me as a doctor, and it was a less acute kind of thing, and they actually chose to leave rather than be seen by me. So I know the other side of that as well. So I've seen that experience as well. And as I've gotten older now, it's really interesting. So when people see me now, they're still surprised to see a black doctor come into the room, and it's such an interesting exchange. So I'll say, hello, I'm Dr. Tweedy, and then they'll say, they'll pause, and they'll say, I have a black friend. It's like, oh, someone in my family. So it's like this idea that they're so uncomfortable with this idea, they have to find a way to kind of make themselves feel like it's okay, right? And so it's interesting because like that's the very first. They don't even say their name; they just go straight to that. And so, but you know, so it's a. But when I was younger, these experiences were much more difficult and challenging. So now I try to develop a sense of more I tried to try and see, this will help me cope with it because, you know, these things are really hard when people sort of reject you for something that, you know, just because of your, you know, way you look or something, right? So how do you sort of cope with that? And so I've tried to identify in some ways with them and try and put myself in their minds and try and think about their narrow experiences that they've had and how that maybe has influenced their ignorance in some ways. I've tried to do it that way. It works for me better. I mean, it's allowed me to cope better with these harsh realities of life. So that's sort of how I make it work for me. Yes, ma'am.
Hi, my name is Imani, and okay, so you talked about how you made the conscious decision to acknowledge people as individuals, like to, I guess, break the ice. But do you think that if you were a white man, then that would be your like initial instinct if you were working with a black patient, or do you feel like that's something that?
So I'm sorry, I didn't mean to cut you off. You said if I were a white man, would it be? I'm sorry.
Yeah, like, do you feel like the reason you did that is because of who you are and not, like, if you weren't who you were, then that would be something that you would take into consideration if you were dealing with a black patient and you were white?
It's a great question. I've seen white physicians do that and do it really well. So I don't think it's like something where you, as a white doctor, you're not capable of doing that. I mean, there's certainly some who don't, but I think there's the ones who get it and they understand, they get it, they are able to do that. Because I think that's so crucial to actually getting anywhere with the patient. Because you can come into the encounter with all the medical knowledge in the world, but if you can't communicate to the person the way in which you can sort of, they can buy into what you're saying, then it doesn't do you any good. And so I think real good doctors get that. That's what I would say. But again, it's not every doctor, but that's the goal, and that's where we need to be. Yeah, absolutely. Wouldn't you say, doctor? Wouldn't you agree with that? Yeah, I'm putting you on the spot. Yes, ma'am.
Hi. You talked about how when you walked into a room, you noticed that people would just jump right to like saying that they had a friend. Do you see a difference within like the generations, like how younger people react to seeing you?
Yeah, it's definitely an older thing, right? It's definitely older white patients you'll get that reaction from. So, you know, so one of the thoughts that kind of goes through my mind, particularly I'm in North Carolina, so I'm wondering like, you know, it's weird. Like, I mean, these person's 80 years old or 75 years old, and you know, what side of the history were they on in the 50s or 60s? That thought always comes to my mind. Like, were they one of the ones who was pushing for change, or were they someone who was trying to keep things the way they were? And those thoughts will definitely come in my mind as I see people. And so I think so in some ways it's an awkward encounter for both of us. Right, in that way. But it's definitely a generational thing. And speaking of generational thing, sometimes with black patients you'll see this. And again, it speaks to our legacy of segregation and second-class citizenship and all that. So there'll be some black patients, particularly older ones, who will be skeptical and seeing a black doctor. They'll wonder, what's going on here? Like, is there something amiss here? Because they're so ingrained and accustomed to this idea that only a white person can be a doctor, sort of thing. Now, again, younger folks, that's not the issue at all. But this generational thing is really there, for sure. Yes, ma'am.
Hi, my name is Fatu. I just wanted to say thank you for coming because I'm a peace studies major, so going to conferences like this is very important. So thank you for that. But my question is, how do you deal with racial issues in the education system? Because I find it like really difficult to deal with being in a prominently white institution. Sometimes when I want to correct someone for saying something racially wrong, it's hard because I don't want to come off like, oh, too aggressive, because the stereotype is like, oh, she's black, like she's about to curse me out or something type thing. So I guess I'm just asking advice. How do you deal with that in the sense where you're trying to acknowledge like, okay, the person is ignorant and you're not trying to come off as aggressive, but then again also like correcting them because that's the right thing to do?
That's difficult. It depends on the situation, what you're trying to accomplish. So, like, think about it in the doctor-patient standpoint. So, if I'm like upset with some colleague said something, but it's, I like to think about it this way. If I feel like it's affecting the patient's care, I try to make it about the patient and not try to make it about here I am. I'm trying to correct you or I'm trying to attack you. This is about how can we make the patient's care the best. So people tend to be much more, so in a medical setting, people tend to be a lot more receptive to that versus just me attacking you and saying that you're wrong kind of thing. That often doesn't go well. But you know, I've had experiences where there's time, and so the way the book is framed is framed as a really sort of, it's really much more of a telling the stories more than sort of setting out an agenda about things. And so there's things in there where I don't look so great because there's times in there where I haven't spoken up and I kind of felt like I should have. And so that's one of the things that I've struggled with. But I think for me, what I've learned is I have to sort of pick, as I get older, pick the battles. There's some things that are worth making a point about and others that aren't. So like, you know, I'll give you an example of something I feel like. So, you know, a nurse one time said something just really kind of silly to me. She's like, oh, you're so tall. You must eat fried chicken and watermelon. And so, you know, I mean, that's stupid. I mean, that's a stupid comment, right? But I feel like, okay, you know, here's a case where this is an ignorant person. I could waste my time yelling at her. I'm never going to see her again. I'm just going to move on. But then there's other cases where things have affected patients, and I feel like I had to step up, and this is going to affect another person. Like I can move on from that. That's her stupidity. That's her life. But in other cases where I feel like I have to sort of speak up when I feel like someone else is being affected. And so that's sort of how I've been able to sort of, you know, cope with these situations and pick battles. Because if you just constantly fight, sometimes what I've seen is that many students, I've seen many black students, like in medical schools, kind of lose sight of why they're here, what they're doing, and then actually struggle academically as a result of all this external stuff that they're trying to, you know, deal with. So you have to kind of pick your battles. Who's, I don't know, I guess we'll go boom, boom, yo. So, yes, sir.
How you doing? My name is Mugadeen Poole, and my question is about education. So in Brian Stevenson's Just Mercy, he talks about how many people don't have education and they fall into these faults.
Absolutely.
And how do you see us changing the education field so that more black men can become doctors and more people they are more on track to becoming more successful in the black community?
Did everyone hear that question? Yeah, about, you know, education. So you referenced that book. So you've read his book, Brian Stevenson? Yeah, it's a really good book, right? And yeah, so he's talking about how do we, a lot of these problems are stemmed from education gaps and deficits. There's no doubt that that's probably the largest issue, right? And so there's a lot of issues there. I think it's more than just a system. I think there's also like a narrative that this country has invested in what the role African-American men will play in it in some ways. And I think that that's also a huge, I gave you some personal examples of how people think, well, I can only operate as a, as a basketball player. That's my role in society. So, in the story, I give an example of seeing a patient in the hospital, and they're like, gosh, there's some people that were like, wow, how do you do this? How are you a doctor, and then how do you go play basketball? And so it was almost like she thought I was like Clark Kent and Superman or something, where I could, be a doctor and then change to my basketball jersey. It was this crazy sort of thing, right? But she was really earnest about it. But then there were other patients that would say things really mean. One guy was like, well, you should only, someone that looks like you should only be playing basketball and nothing else. And it was like, wow. I mean, so that's how you. And so, but I think those kind of projections or in society are there, and there's like certain narratives of what role black men are supposed to play. The media does a really bad job of sort of reinforcing that or actually perpetuating that. And I think that really influences, I don't want to bash the media here, but because that's an easy target, but I think it really does perpetuate some of these stereotypes in ways that are really poisonous. And they're so poisonous in that I think they in turn infect not only the white society, but they infect the black society and how they in turn see themselves and their own roles in society. So I think that's a huge part of like when you're talking about school and and there's a perception that the media has that that's not something that black men do, and or somehow it's uncool and all this kind of stuff. So I think there's so many other forces that are at work there, right? But then there's more practical things about how do we improve schools. I don't think I have great answers for that. I mean, that's not my field as far as how do we fix the education system. I mean, there's so many problems. But again, it's the issue we can't give up. We got to keep fighting. But I think that whole issue of the focus of the narratives. I think that plays such a big role, even more than I know. A lot of schools are terrible. I've been to some schools that weren't so good, but I know that's a problem. I think the narrative is equally a big of a problem as well. How do we change that narrative of what it means to be a black man in our society, and not just be perceived as a threat or something like that? I think these are issues that are infecting our whole world in so many poisonous ways. So. But maybe that's the answer. Maybe that's something you can figure out one day, and then I'll come back and ask you what you've done to fix this problem.
My question was very similar, just about in the past few years how there have been states that have outlawed the use of affirmative action in medical school admissions, and what you saw the role of medical schools or where else in the education system again that we can kind of fight that deficit of, you mentioned the statistic from 1970 to I
Yeah.
think it's 2014, the poor representation of African Americans in physician roles. Where do you see medical schools and how now fix that gap?
Good point. So good question. So medical schools, there's a couple issues. So some medical schools will take a very passive approach to admissions process. Well, they'll just sort of say, okay, well, whoever comes, it implies, we'll look at your application and, et cetera. And then they're saying, well, we're being really fair. And then they'll throw their hands up and wonder why is no one applying, sort of thing. But they're taking a really passive approach to it. Then there are other schools that actually take a much more active approach. And they're actually going out to like maybe historically black colleges and places where there are black students that are there who may be very qualified, but for various reasons don't think that this is a place where they could go. Right, and so it's like taking an active role versus the passive role. And I think that's one part of the issue there is how schools approach that. On the issue of affirmative action, I certainly benefited from that to the extent that, the thing, my parents had not gone to college at all. When I got to medical school, my classmates, half of them, their parents were doctors, and they were like department chairs and all this other sort of stuff. I was like a totally different world, right? And so this idea that we get sort of focused on test scores have their usefulness, but they also don't to some degree. So, my MCAS score was lower, but you think about the gap that I had in all the experiences that I had to overcome to get to the same place. And so when we got to the same place, I was able to do as well or better, but, as many of these students. But again, it was you have to take into account the whole student's journey and not just look at a score to represent, their value or worth. So I think it's about looking at a bigger picture when you think about choosing students. And it's not just race, it's also about your social class and about all other sorts of factors as well. But I think we're getting when you say merit-based, what is, that's a nebulous kind of term in some ways. It's much more subjective than it actually seems.
Since you use the term bigger picture, I'm curious, what are your thoughts about the impact of the Affordable Care Act on something like racial disparities?
Yes.
And or what, if we're going to absolutely have to move to something of a Medicare for all or single payer type thing to really include everybody and to resolve these disparities, or what do you think?
Great question. So I touched on this the last time. I didn't. Someone asked me this the last place I was in. I didn't answer it the right way. I keep thinking about I didn't answer it the right way. So I talk about the Affordable Care Act. I touch on it a little bit at the end. The focus of my book is really much more on the stories of people and their experiences, not so much on the policy side of things. But yeah, the Affordable Care Act. So I talk about it at the end because I think it's helped to some degree, but it's also been very limited in some ways in its impact. Take a state like North Carolina. So one of the ways in which they were trying to expand health insurance was to increase Medicaid, right? It was one of the ways in which you could expand it. Well, several states have taken it upon themselves to reject the expansion. And those states happen to be the states that have the largest population of poor black people. So North Carolina being one of those states, right? And so you have this situation where you're it's been undercut in many ways, but I think we do need a system where everyone can have health insurance. But how are we going to get there is the problem. We have it's this politicization. I understand there are issues in life that are always going to be political. They need to be political. Healthcare just seems like it's everyone gets sick in the same way, same problems. There's no political party breakdown or illness. It's all the same. And so it seems like if one issue could be one where we could find a way to agree on a bipartisan issue, that would be it. But obviously that's not our reality. And obviously it's up in the air. Depending on what happens to the election, you have no idea what the future of it's all going to be. There's a lot of things that are still really uncertain with that. But certainly that's at a minimum, we need to have a system where people have health insurance because it's just amazing to see someone who does not have health insurance in a different level of care. So what I try to visualize in the stories is to show how different that can be. And then when you think about people being uninsured, then this is about the narrative part. So people will have all these sort of negative stereotypes about what it means if a person doesn't have health insurance. But that narrative is often not true, but that's a narrative that's sort of been allowed to be sort of fostered out there. And it's also poisonous, and it's also caused inaction. And so I think we're in a really challenging time, and it's an issue that we really have to fight for. Yeah. But it'll be interesting to see what will happen 20 years from now. I don't know where we'll be with that, but we need to get better. Yes.
Okay. Earlier you kind of mentioned the almost like, I guess, different treatment from being a doctor or a medical student versus just being your average day-to-day black man in sweats and
as a patient,
whatnot.
Right.
And I guess my question is centered around that of how do you switch from role to role and know that you have different treatment when you're dressed a certain way or perceived a certain way? And then how do you, I don't know, teach that to your kids?
Oh gosh, great questions. Whoa, am I ready to answer that one? So like, how do I deal with the being sort of like these two different versions of myself kind of thing? That's one of the themes in the book actually comes up a lot. There's a term called, when I have slides, I have a slower show slide. It's called like a double consciousness. You guys are familiar with that terminology? W.E.B. Du Bois is a famous black philosopher from the early 20th century, first black person to graduate from Harvard and something like that in a PhD. And there's a term called double consciousness, this idea of always sort of seeing yourself in two different realms. Like you see yourself in respect to how, like for instance, in his time, how white people would view you, but then also seeing yourself in respect to how black people are viewing you. So it's like being this sort of two people, having these dual identities. And that's a theme of the book, because many of the patients, it's a theme that goes throughout the book, because many of the patients that I would see would be patients that in many ways reminded me of members of my family, similar to my cousins, friends, people I grew up with. But at the same time, I had become part of this medical system, which was very privileged and well-to-do, and I was sort of like trying to navigate these two worlds. And at different times, I had to sort of figure out where was my place in these two worlds, and that was sort of an ongoing struggle that I would face. It's something that it changes as you go through different phases of your life. As far as the answer for the kids, I haven't figured that answer to that one yet. I mean, they're still 8 and 6, and there's a part of you that wants to just sort of protect them in the innocence and the naivety, but then there's also this reality, they're going to have to face at some point. So that's a challenge, yeah. It's the first time someone's asked me that question. I'm going to be thinking about that one all the way back home. But yeah, so I mean, do you find yourself as a student sort of experiencing that kind of dual thing? Some of the students, yeah, it's a real issue for sure. Yeah, and so that's something I really wanted to capture in the book.
So how do you think intersectionality plays a role in healthcare and the healthcare profession? Like, is it easier for men because of the male privilege, or is it because of the society that we live in?
Can you clarify that? I'm sorry, I'm not, in medical world, I'm not that smart about things. You said intersectionality. I've heard that term, but can you clarify?
So it's basically like looking at
learning something new here.
It's like looking at different aspects of a person. So like, for example, I'm like female, but I'm also Asian. So I have the difficulty of dealing not with only female issues, but also Asian issues as well. And so like, how does intersectionality, so because you are male and black, how do you think it affects like women who are black in the healthcare profession?
See, what a good doctor can do is, because people have different identities, right? So people can be many things, right? There's many ways of defining yourself, and what a good doctor can do is distill what's important for that particular individual that they're seeing, and be able to be facile with all different aspects of their identities, but be able to identify what's most important in that period of time. So it could be a case where the identity of being a woman or being a mother is the most important identity in that particular moment in time where you're seeing a person, right? It doesn't always have to be black, it could be different things. And being able to identify what is the most important thing at a given time is what a good doctor should be able to do. Yeah, I mean, women certainly have their own, I mean, my wife is actually, so she comes in, she's like a kind of, I want to say minor character, because she's certainly not that in my life, but in the book, I don't talk about her a lot in the book, but we went to medical school together, and so she's from Jamaica originally, and certainly in her experience, she's had a lot of experiences that have been much, maybe more geared towards the woman's side, but then there's some that intersect. There are times when it's both, and it's hard to tease out. So when she first got her practice, she started in a community that was an underserved community, and they were going to pay for her medical school, help pay for her medical school loans, and that's why she went there. And in this town, so we went to this, when she first day she walked into the hospital, they were like, first thing they said was like, "Who are you? And what country are you from?" And she sort of looks kind of Indian more, but she's from Jamaica. And so that was like the first thing they said to her. And then we went to this medical society party. And so, we're used to being the only black doctors kind of thing. That wasn't so surprising. But when we got to this medical society dinner, there was only one other female physician. It was like amazing. It was like, this is 2005, and there was like one female physician in the town and like 100 doctors. It was amazing to see that. So there's still issues there as well that still come up a lot. No doubt about that. Yes, sir. Got a good, interesting group of students. A lot of good questions here.
You touched briefly on how the expectations the community has for the kids can affect the paths the kids can see for the future. Could you maybe elaborate on how how that maybe affected you or affected other people around you as far as what they believe they could do in school and once they were done with high school.
Yeah, so it affects it a lot. So I mean, I gave you a couple examples of how people were telling me that I could only go to college if I played basketball, those sort of things. So there was another guy in our neighborhood who was more advanced in terms of his science and math skills. He was a couple years behind me, and he'd gotten to the same program. But again, he was and he'd been told that same thing about you can only go to college if you play basketball, kind of thing. And he really, this was just so, and he wasn't actually that tall, he wasn't that good at basketball, so it was just like, what are you even talking about? But in this case, he really sort of embraced that narrative more so than I did, and I think that did lead him amiss, in terms of, he didn't get into legal trouble or anything, but he just didn't he didn't reach his potential in any way. And I think those sort of forces played a big role in that. That was just one example. I think there's a lot more, a lot of people like that. If they were able to see a different way at a younger age, because part of it you have to get at a younger age. If you get too far along in life, it gets harder to sort of catch up. So getting people at a younger age is also a big part of the puzzle as well. But I think we can never sell short. Even in this 2016, there are people who are being told they can't do stuff, and then how that in turn impacts, how they see themselves. I mean, that is still happening, 2016. Yeah.
In your book, you talk about being racially paired with patients and how sometimes that was an advantage, sometimes that wasn't necessarily an advantage. And I was wondering, as a white physician, if you think it's possible to ever gain the perspectives that you might need to have the same impact as a black physician in a similar situation.
I don't think the answer to this problem is that black people are the only ones who can solve this problem. I think these are problems that are much bigger than that, is much more rooted in a longer history. I think if as a doctor, patients mostly want to know that you listen to them and care about them and will listen and give them space to talk. So a lot of times patients who come to a setting and they're not well educated, they come with an expectation that people are not going to treat them well, right? It's sort of been kind of, they've had that experience and that's what they sort of come in expecting in some ways. So I think I've seen really good doctors be able to, break through that and establish great relationships with the patients. It's all about giving the person a little bit of space to be heard. And sometimes it may be that they have to talk about something for a few minutes that doesn't seem like it's relevant to what your role as a doctor is, but it makes a huge difference in the long run. So I think there's a great role for that. So I would never sort of sell yourself short and thinking, well, because I'm not black, I can't help this person. I think that's something that's, in some ways, that's sort of letting yourself off the hook in a way. So I think that's a really important thing. Yeah. Yeah, don't sell yourself short.
So in your book, you describe a case where I think you're doing your rotations in the emergency department, and a woman comes in and she's having premature labor, she's bleeding profusely, and you're the first doctor there asking her questions,
I was looking for some water. Yeah.
One of them is, have you taken any drugs in the last, X amount of days or whatever?
Right.
And she denies it. And then later I think it was the attendant comes in or something, and she comes in and kind of in an accusatory tone says, when's the last time you smoked crack? Mm-hmm. And she says 2 days ago. So my question for you, I guess, is is there a place for stereotypes, I guess, in medicine?
Yes, so stereotypes are abound in medicine, totally abound in medicine. And so that's sort of how medicine is taught in so many ways. Like when they teach you to take tests, they sort of have this, when people are presented, so when a patient comes in and they present like a patient's in the hospital and the student presents the case to another doctor, they'll always start off with, this is a 30-something year, they'll give the age, they'll give the race, and then the gender. So age and gender are really important when you think about different sorts of health problems. But race is sort of grouped in that first set. And there's a lot of controversy about whether that's a good or a bad thing, because it can really be problematic. There's some diseases where race is really important. Some is clear, but then there are others where more often than not it's not. And so it can be used in really bad ways. And so to give you a similar example along the lines of drugs, one time I was in the ER, and this story wasn't in the book, but it was a guy, he was 45-year-old, like black man with chest pain. That was sort of the initial line that was heard. So the way medicine teaches you, you're supposed to already form different thoughts about what could be going on based on his age and based on gender and all that. So, I'm thinking, well, chest pain, heart, right? It's in the heart. What else is in the chest? Lungs. You guys know that, right? So I'm just kidding. So I know this, I'm just kidding for you guys. So here's the thing, though. But the first thing the doctor said was, So did he smoke crack? That was the very first thing he thought. So a guy comes in with chest pain, and he's middle-aged. The very first thing, because he's black, very first thing he said was crack. Completely wrong, completely off. But so that was a really very problematic way of looking at the situation. Now back to the story. But you see that could be used for wrong. Now back to the story in the book. So the way the story in the book was put in, it was really more of an issue of me not being experienced. What I was trying to convey in that story was this idea of someone being really struggling, me being a really inexperienced. I was actually a medical student. I wasn't a doctor at that point. I was a brand new medical student, didn't really know how to interview patients. And so even though the doctor got the information, I was still struck by the way in which she came about it. And in the end, it didn't really help clinically, but I was struck by the way in which she approached this patient and wondering would that ever happen in other settings. So I was still sort of left with this feeling of, is this the right way to treat someone, even if you are getting the right answer, sort of thing. It was kind of a struck. But I would say on balance, I think that that's a problematic way to sort of approach patients. If you can give my sort of short answer for that. Yeah. Wow, you guys read the book and you got some really good questions. Thank you. Yes, sir.
Hi, my name's Tremaine, and a lot of your stories kind of talked about where you thought that racism and stereotyping and stuff was, years ago. I'm just kind of curious at where you think things are racially and in that sense in 2016 and where things will be, 5 years from now for us nursing majors or future doctors.
Where things will be in terms of race as far as healthcare?
Yeah, yep.
Gosh, I think there's still tremendous, healthcare in many ways is a reflection of what's happening in society. So if there's problems that are happening in society, it's going to bleed into the healthcare world. The doctors will try and give you the sense that it's completely separate and that medicine is completely objective and it's all science-based. And that's sort of how they try and teach it to you. But you'll see that, whatever's happening in the outside world is going to affect what's happening in the medical setting. So obviously there's things in the outside world going on that we're still problematic and we're still trying to grapple with. I would say, though, that things are a lot better than they were, say, in some ways better than 25 years ago. Even if you look at objective data in terms of the life expectancy gap closing, infant mortality rates are lower. Things actually, so we hear all the negative stuff, but things actually, if you look at actual data, things have actually improved in ways. So I think we're making progress. Clearly, progress is not quick enough. Clearly, with progress, there's this resistance, and we're going backtrack in some ways. So it's a complicated story, but I think that I'd be hopeful. Yeah. Any other questions? Oh yeah. Okay.
I just wanted to know, what encouraged you to pursue being a doctor, and what was that point in time when you decided it'd be a good idea for me to go to med school?
Yeah, I think one was that program I told you about, got a Magnet program in high school, and then when I was in college, went to college at the University of Maryland. When I got to college, I did a summer internship after my first year, met a African-American cardiologist, a heart doctor, and he was a young doctor. It was the first time I really met someone who was African-American, who was young, and he's a doctor. It was amazing. It was wow, this can really happen, sort of thing. And it seems crazy to think that, but that was where my experiences had led me to that point. And he showed me around, met some other African-American doctors and students and medical students, and I said, oh, gee, maybe I could do this too. And that was really kind of the beginning of me sort of thinking about medicine specifically. Now, a lot of times people ask, well, how did you get into psychiatry? I'm still wondering that. So the truth of the matter is, when I was in psychiatry, when I was in medical school, you rotate through all these different rotations. And psychiatry was my one rotation. I really did not like it at all. It's not like psychiatry. And then I don't think that they liked me very much either, based on the grade they gave me at the end of the rotation. So at the end of the rotation, because you have to interview a patient, and you have to interview it, and then you have to sort of in front of the faculty member, and you have to sort of describe what you found and what you think is going on. And I did such a bad job. I was cutting the patient off and interrupting him, and the doctor said, sir, you passed, but I think you should think about being a pathologist who doesn't see patients. So somehow I took that to heart, and I got a lot better at interviewing people. And the thing about psychiatry, though, on a serious note, is that a lot of the issues we talked about in terms of all these issues of disparities in treatment, in psychiatry is even more pronounced than it is in any other area of medicine. It's incredible. It's absolutely unbelievable. So when someone comes to the hospital, the first thing you should want to know is what's wrong with them? How can we help this person health-wise? Psychiatry, when you're in the emergency room, what we find out is the very first thing you want to know, more than anything else, do you have health insurance? And if so, what kind? That was that question was more important than anything else to know about the person, because that would totally dictate what you could do. And so this story really illustrates sort of the disparity. So one night in the emergency room, I'm in psychiatry, and I see consecutive patients, back to back, 2 women in their mid-20s, exact same basic story. They've both been depressed, and they both had sort of thought about, sort of kind of fleetingly thought about suicide and had taken some pills. But the short of the story is that they both needed to kind of come into a hospital for a few days to sort of get their bearings straight. 2 women, same story, same age. One was black, one was white. One had health insurance, one did not. So the one that had health insurance, she goes up to the unit where there are people, you get your own room, you get to see a doctor who kind of comes and sees you, talks to you every day. The people in the unit are very similar to you, so it's like an environment that's going to be appropriate for someone with her problem. Nobody wants to be in a hospital like that, but it's an appropriate environment for someone with her problem. Second patient, no health insurance, can't go to that unit because you won't accept people who don't have health insurance. Tried other hospitals in the area, nope, no health insurance, can't come here. So only option for her was state facility. So a state hospital is a very different animal. So state hospitals where people go when they're like commit crimes and they're waiting, insanity determinations. People who hurt people who are really violent. You share a room with other people. So it's a very different environment, right, for a very young woman who's sensitive and kind of brittle and frail to go into that kind of environment. But worse than that is that how do you get there? So you can't just get there from that one hospital to the other. Because she's been deemed like someone who might hurt herself, you can't just go by an ambulance. The ambulance says, well, we're not going to do that because we're not going to take responsibility for that. So what do you have to do? You have to call the police. And the police come, and the police actually, she may be hurt, she may be dangerous. So we have to like put her in her little, like kind of police uniform kind of thing, prison uniform. And then we have to put her in handcuffs because we don't know what she might do. So her first experience with the mental health system is she winds up being treated like she's a prisoner, right? She goes in the handcuffs in the back of a police car to a hospital, all because she doesn't have health insurance. It's unbelievable, right? I mean, so this is the reality of some of the experiences that we have. So I was so blown away by this reality, and mental health is so much more of a problem. Another case is that you have someone who has a drug problem. Drug problems are really common among all parts of society. Someone has insurance. Okay, we can send you to the program, 30-day program, get you top-notch care, everything you need. Don't have health insurance? Oh, we'll get you there for 2 days, and you got to go home. And it's just like, it's just simple as that. So me being in mental, so that actually drew me to mental health because I knew that there was this tremendous gap in care. Then I also had some personal friends who struggle with mental illness that I didn't know before, and then they developed mental illness along the way. And so these things really drew me to mental health because I feel like I could make even bigger contribution because these needs were even greater than they were in other areas of medicine. So that's what ultimately kind of drew me to mental health. Even though initially I grew up with a community that had a tremendous stigma against mental illness, but that sort of really drew me into it. So these stories are just incredible, what's happening on the ground in the real world. Yeah. So it looks like we're done with questions. So thank you so much for being patient. I know it's late. It's a pleasure. So just remember that thing about that quote from Dr. King about doing small things in a great way. I think these problems are enormous, but there's always small ways in which each of us can make a difference in someone else's life. Never lose sight of that as you move forward. I think that's just so critical as we move on in life.
Thank you all very much for coming. Dr. Tweedy will be signing books out in the lobby if you're interested, and also representatives of the groups, the 4 student groups that I mentioned that are co-sponsoring this conference will be out in the lobby as well. So thank you very, very much, and thank you, Dr. Tweedy.